Good morning, good afternoon, and good evening to you all. Hope you're all doing well. I'm Dr. Hanady, and I will be explaining to you the methods of gaining space in orthodontics. This topic will be given to you on 2 lectures, a part 1 and a part 2 lecture. وليه احنا محتاجين space؟ في كتير من حالات المalocclusions we need to create or make space في الarch so we can align and level the teeth in a perfect dental occlusion. مثلا احنا محتاجين space لما يكون عندنا crowding في السنان. يعني ايه crowding؟ لما يبقى sum of the tooth material أو mesiodistal dimension بتاعت التيث من 5 to 5 is more than the arch parameter. They result in crowding. In another way, is space required بسبب tooth material is more than the space available. Space available هو ال dental arch parameter. ده because crowding من الأسنان. To align and relieve this crowding وأعرف أرتب السنان, I need space. In another case, if I have a deep bite. What's a deep bite? It is an increased في overbite. لما upper anteriors بت overlap more than 40% من السيرفيس بتاع lower anterior. ودي زي ما انتوا عارفين it appears in class 2 cases زي ما أخدته بيبقى accompanied معاها exaggerated lower curve of spine. If I need to correct this, I have to level the curve of spine عشان correct a deep bite. And I need space. In cases, some cases come with a proclined or protruded upper teeth or an upper and lower teeth, and the patient complains from the protrusion and having a bad profile. To retract these teeth, we need space. Another condition, when a canine becomes impacted. An impacted canine, we need to pull it back in the arch, in its place, and it requires space. Also in a class 2 and a class 3 malocclusion, as you know, you have an abnormal molar relationship. And we need to correct this molar relationship into a class 1 molar relationship. So we need space. If there is a rotated anterior tooth, and you know that the mesiodistal dimension of the anterior teeth is more than the labiolingual dimension. So it requires space to be aligned in the arch. In cases of a posterior or an anterior crossbites, السنة عادة بتبقى out of the arch والspace بتاعها بيبقى lost by the movement of the neighboring teeth. So I need space to be able إني أرجع السنة تاني مكانها and correct the crossbite, whether anterior or posterior. Also in some cases when we have a collapsed arches or constricted arches, we need to align the arches, whether anteroposterior or transverse or both, to be able to have a proper occlusion with the opposing arch. طيب ايه هي بقى methods that we use to gain space? These methods هينقسموا 2 major categories. First one, non-extraction methods. The second one, extraction method. Non-extraction method, these are non-invasive methods. Why called non-invasive? It's methods without extraction of the teeth. يعني ما بنخلعش فيها. زي ايه؟ في عندنا proximal stripping, expansion للarches, distalizing of the molars. ممكن نعمل proclination للanteriors. نعمل derotation of the posterior teeth أو uprightening of the molars. Second category اللي هي therapeutic extraction, in which بقى بنعمل فيها extraction للتيث. ممكن we can extract 1 unit, 2 units أو more. depends طبعا على ال diagnosis وال treatment plan إن احنا حضرناهم للبيشنت. بس الريزن هنا for extraction for treating ال malocclusion. عشان كده بنسميها therapeutic. We will start with the non-extraction methods first. ايه بقى اللي يخلينا نختار non-extraction method over extraction؟ حسب الحالة اللي بتجينا. مثلا لو فيها the amount of crowding about 8 mm or less يبقى I go with non-extraction. زي ما قلنا يبقى ال space required اللي أنا عاوزاه 8 mm or less. في بعض الحالات لما بيبقى عندي المولرز are mesially tipped أو lingually tipped. Also لو ال arches is constricted. لو constricted أنا ما بخلعش عشان هيزود ال constriction ويبقى more collapsed. ف I do not go with extraction. In the condition إن ال cases دي بتبقى due to dental cause not skeletal. ال causing مش skeletal problem فيها. It's dental. يعني السنان العيب في السنان بس مش في البيزل بون. Again لما بيجيني patient والfacial profile بتاعه كويس و acceptable. I do not go with extraction. I go with non-extraction. علشان if I go with extraction I will worsen the profile. هبوظ له البروفايل بتاعه. وهو البروفايل بتاعه كويس. فأنا مش عايزة ألعب في البروفايل بتاعه فمش هخلع. Also I have to have a cooperative patient يبقى متعاون معايا and to follow instructions عشان most of the non-extraction cases بتبقى فيها appliances ولازم يلبسها فلازم يبقى cooperative ويسمع الكلام. We prefer a growing patient علشان we use the growth عشان afford السبيس اللي احنا بنعمله ويعمل catching up معانا to the expansion for example. هنبدأ نتكلم على non-extraction methods ومنهم ال proximal stripping which is also known as cylindrization, reproximation, slicing, disking or interproximal reduction. And you have to learn these names too. في الميثود دي it's commonly used في حالات لما يبقى فيها mild أو minimal space is required اللي هو ما يبقاش أكتر من 2.5 ملم. In this method احنا بنعمل reduction يعني بنشيل enamel من ال proximal surface اللي هو الميزيال والديستال surface فبنقلل الميزيو ديستال dimension أو الواتس بتاعة السنان اللي بيخليه يفتح لنا فراغات ما بين الأسنان. This image shows clearly the spaces that has been created after performing a proximal stripping to the lower right and left lateral incisors. يبقى احنا زي ما عرفنا وقلنا قبل كده امتى بنستخدم البروكسيمال stripping؟ بنستخدمها لما يبقى فيه minimal space is required. لو space not more than 2.5 mm is needed. ساعتها I go with stripping. طيب امتى بتبقى المينيمال space required في أي حالات؟ لما تجيلي حالة وعندي فيها الكراودينج about من 0 ل 2 mm maximum. يعني ايه الكراودينج؟ زي ما قلنا ان التوث ماتيريال بتاعتي التوتال بتاع السم بتاعتها بتبقى more than الارش بارامتر ب 2.5 ملم ماكسيمم. دي ممكن go ahead with stripping. Another case لما اعمل Bolton analysis. Bolton analysis دي بتدescribe التوث size discrepancy ما بين الupper والlower arch. يعني ايه؟ يعني بتدescribe me لو في تناسق ما بين السايزز بتاعت الأسنان اللي في الupper arch ماشية مع السايزز بتاعت الأسنان اللي في اللور arch. علشان لو هما اوكي in harmony يبقى هما ايه؟ having result هيبقى good over jet, good over bite، هيبقى الكيناين والمولر in a class 1 relation. لو حصل أي disturbance في السايز ما بين الupper والlower whatever anterior or posterior البولتن analysis بتوريها لي وبتقول لي الاكسس فين بالظبط، هل في الانتيريور تيث أو في الهول arch كله، وبتقدر تحددها لي وتقول لي الاكسس قد ايه بالظبط. لما بعمل البولتن discrepancy ويطلع لي ان في difference excess from maxillary arch عن المانديبولار arch for example، وبيقول لي الاكسس ده is less than 2.5 ملم، يبقى أنا I can do stripping في ال upper maxillary teeth وأظبط ال two sizes مع بعضيهم علشان again a proper أو favorable overjet و overbite و I get a good class 1 molar and a canine relation. Another condition بيبقى علشان أزود ال retention وما يحصلش relapse عندي في ال lower anterior region، وده بيحصل إن لما بعمل stripping أنا بغير ال proximal contact from a point contact to an area contact، وال area contact somehow لقوا by researchers إنها it resists relapsing فبتبقى more favorable for retention. One is stripping contraindicated. بنبعد عن الستريبنج في البيشنتس لما بيبقوا عندهم enamel hypoplasia، بيبقى الانامل بتاعهم ويك، فلو انا عملت له ستريبنج هيحصل more liability للكارث عنده. Also لما بيجي لي patient وعنده a lot of caries cavity فوقه او a lot of fillings inside his mouth، يعني معنى كده ان هو عنده الكارث susceptibility عالية، فانا ما اقدرش اعمل له ستريبنج لان هو more liable و susceptible للكارث. في الحالات البيشنت بيبقى جايلي وهو عنده very bad oral hygiene، if I do stripping I'm weakening enamel وهو ما بينضفش كويس فبيبقى more susceptible للكارث فما اقدرش اعمله stripping. في اليونج age بيبقى عندهم large pulp chamber so I have to pay attention اني ما اعملش stripping لان ممكن لما بعمل stripping بيبقى في risk ان انا اعمل exposure للبالب. One of the advantages of proximal stripping is that we avoided extraction and we also avoided the complication that might have resulted from extraction, especially in cases where minimal space is required. طيب ايه complication اللي might have resulted مع extraction؟ زي sometimes بيبقى فيه لما بنخلع السبيس بتاع extraction بيبقى very difficult and takes a longer time to close. Even after completely closing the space, it might reopen again. And one of the causes بتبقى سبب reopening in lack of parallelity بتاعت roots of the teeth next للextraction site. يعني ايه؟ يعني for example لما اجي اخلع the first premolar by the end of treatment after space closing مفروض الروت بتاعت second premolar والcanine يبقوا parallel لبعضهم. Again, sometimes it requires ان احنا نقاد appliances for anchorage زي النانس appliance, transpalatal appliances زي lingual arches, sometimes even mini screws. طبعا other advantages اللي معروفة وكلمنا عليها إن stripping بيديني favorable overjet and overbite، بيديني more stable results، زي إن هو بيaid في الريتنشن زي ما قلنا قبل كده. من ال disadvantages للproximal stripping نحن ممكن واحنا بنعمل reduction للsurface ما نعملش polishing و finishing كويس ونسيب rough surfaces that accumulates food وتعمل food impaction و could lead to caries، فاحنا بنزود له ال caries susceptibility. برضو in some patients ممكن يحصل لهم sensitivity بعد ما نشيل لهم layer من الانامل. من عيوبها برضو ان ممكن واحنا بنعمل reduction we do not keep the shape of the tooth ونغيرها فبتبقى شكلها بعد كده unaesthetically. ومن الحاجات التانية برضو ان لو عملنا reduction ممكن ما نعملش proper even reduction، ممكن ناكل في حتة اكتر من التانية، فلما بنيجي نقفل السبيسز التوث كان touch في areas و areas تانية بتبقى lost contact وكأنها opened فبتبتدي accumulate الفود وبعدين تعمل caries again. وهو recommended دايما ان بعد ما بنعمل stripping ان احنا نعمل fluoride application علشان نقلل الكاريس susceptibility والsensitivity اللي ممكن تحصل للبيشنت. لما نيجي نعمل stripping لازم نبقى محددين قبليها السبيس required، يعني الحالة دي محتاجة ملي سبيس ولا محتاجة ملي ونص ولا محتاجة 2 ملي. كمان نبقى محددين أني سنان بالظبط اللي هنعمل لها stripping، ونخلي بالنا ان احنا دايما ما نشيلش انامل اكتر من half الانامل thickness، اللي هو بيبقى عادة احنا بنشيل من each surface around 0.25 ملم، يعني ربع ملي تقريبا. من الانسترومنتس اللي احنا بنستخدمها علشان نعمل بيها stripping we can use abrasive strips، we can use tapered fissure burrs، ممكن تبقى كاربايد أو ممكن تبقى diamond. Also we can use discs. الأبريسيف strips دي بتبقى metallic strips coated diamond particles، ممكن تبقى coated on one side بس single أو ممكن تبقى on both sides بنسميها double sided coating. ممكن تبقى fine أو تبقى medium أو coarse. الكورس بتستخدم للريدكشن removing enamel، الميديوم والفاين بيبقى للكونتورينج والفينيشينج والبولishing. You can see here in the images the double-sided and the single-sided strips also ممكن يبقوا perforated. These strips ممكن يجوا بالهولدرز، معاهم هولدرز ready made بتبقى واخدة different color coding according للسايز بتاعها. الهولدرز دي بتديها accessibility علشان نقدر في الهاندلينج أكتر، يبقى سهلة في الاستخدام عن الستريت ones. The leaf gauges دي بتبقى واخدة measurements accurate measurements بقدر استخدمها بعد ما بعمل stripping عشان أعرف قد إيه الأماونت اللي I removed. We can also use carbide أو diamond burrs عشان نشيل الانامل. Also the diamond discs. These discs بتبقى rotating 360 degree and it's better and recommended to be used مع الجارد عشان تبقى protecting لللب وللopposing teeth. As you can see that the 360 disc can cause damaging to the lower incisors while stripping the upper incisor. Also you can see how the disc is used with the tissue guard. Recently في segmented discs اللي بتركب على الهاد أو الكونترا وبتعمل movement by oscillation back and forth عشان تعمل stripping. It became more popular عن ال 360 discs because it gives better vision للفيلد اللي بشتغل فيه وبتبقى better control.
Here you can see how the segmented discs are used intraorally.
Expansion of the arches is another non-extraction methods for gaining space. It's commonly used in patients with constricted or collapsed arches زي الحالات لما في cross bites anterior or posterior. Again لو في crowding causing collapsing of the arch. في حالات زي class 3 cases لما بيبقى maxillary arch is constricted. حالات برضو زي cleft lip and palate. Also in cases, surgical cases, we use it as a pre-surgical step before a patient goes to surgery.
We can classify the types of expansion according to the rate of expansion or the rate of activation into a slow expansion and a rapid expansion. We can classify it according to the direction of expansion. يعني بفتح في أي اتجاه. Is it anteriorly or posterior? Is it unilateral one side or bilateral on both sides? We can classify it according to the type of expansion. Is it an orthodontic expansion, which works only on a dental expansion, شغال على السنان, or an orthopedic expansion, which works on the dental and the skeletal, so it works on the teeth and the basal bone too. When we compare the orthopedic and the orthodontic expansion هنلاقي في orthodontic expansion إن الفورس mainly بتبقى directed على السنان only. يعني الإفكت بيبقى dental effect only. بيبقى معاها some tissue changes أو adaptive changes that takes place في alveolar bone and the surrounding and moving teeth والadjacent teeth. While في orthopedic expansion الفورس بتبقى directed mainly على البيزل bone بتاعت المجزلة وبتاع المندبل plus directed على السنان. يبقى الإفكت هنا في الأورثوبيديك بيبقى skeletal effect and dental effect. Again بيبقى فيه adaptive changes أو بيبقى فيه tissue changes ودي involve both الالفيولار bone والبيزل bone. Slow expansion is indicated in a growing patient, especially in an early and a mixed dentition stage where minimal space is required around 1 to 2 millimeter زي الحالات اللي فيها mild maxillary deficiency أو a cross bite whether it's unilateral or a bilateral. It is contraindicated in a non-growing adult patient. The advantages of the slow expansion. الابلاينسز اللي بتستخدم للسلو expansion بتبقى light وبتبقى comfortable to the patient. بيبقى الادجستمنت فيها minimal وبيبقى very easily to adjust. بتدي forces بتبقى constant physiological force يعني بتبقى زي light forces مش harmful ولا damaging للتيشيو لحد ما الاكسبانشن بيحصل. As we know in كل removable appliances بتعمل tipping movement only. التيبنج اللي بيحصل مع slow expansion بيبقى very minimal. السترين اللي بيبقى على الانكر teeth بيبقى برضو the lowest. الابلاينس after finishing ممكن we can use it as a retainer itself. retention time فيها بيبقى less والrelapse tendency بيبقى very low. الديسادفانتج والعيب بتاع السلو اكسبانشن بيعتبر التريتمنت تايم بتاعه بيبقى طويل لو هنقارنه للرابيد ماكسيلاري اكسبانشن. الابلاينسز اللي بنستخدمها للسلو اكسبانشن في we have two types يا removable appliances يا fixed appliances. من انواع الريموفبل في الكوفن سبرينج في الاكتيف بليت والفيكست في دبليو ارش والكوادري هيليكس والنايتاي palatal expander والسبرينج جات. The coffin spring is an appliance that consists of an omega-shaped wire of 1.25 millimeters thickness. The ending of the wire is embedded in acrylic that covers the side of the pallet. This appliance we activate it once a week. We open it around 1 to 2 millimeter. الactivation أو opening بتاع الspring بيبقى by holding the two parts apart أو by using a plier. هنا شايفين الكوفن spring appliance وواضح الأوميجا shaped wire اللي embedded في ال two parts acrylic plate. ولما بنيجي نعمل activation للappliance ده بنشد ال two parts قوي بعيد عن بعض علشان يعمل bilateral expansion. The active plate or the expansion screw appliance is a removable appliance used for slow expansion. It's constructed of an acrylic plate that is splitted and incorporates a screw, which is the active component of the appliance. These screws could be of different sizes. They can move a single tooth or a group of teeth. They can move the teeth in a different direction, in an anteroposterior direction or a transverse direction. The expansion screw appliance بيبقى activated once or twice a week. بيبقى له effect على التيث وعلى الالفيولار process. الفورس بتاعته بما إنه removable appliance بيبقى intermittent force. يعني الفورس بتبقى موجودة as long as الappliance in the mouth of the patient. once هو بيشيله من بقه بيبقاش فيه force. This is an intermittent force. We can use it زي ما قلنا in different direction. ممكن تبقى في الترانسفيرس أو يبقى في anteroposterior. الإكسبانشن سكرو appliance بنعمل له activation by opening السكرو واللفة الهول turn فيها بتبقى اللي هي 360 degree بتproduce 1 مليمتر من التوث movement. لما نيجي نعمل activation هو بيبقى فيه 4 holes في الهول turn. يعني each hole بتديني 90 degree activation. يعني بتديني 0.25 مليمتر. يعني بنقول a quarter turn بتديني 0.25 مليمتر من التوث movement. You can see different types of screws. Some used for single tooth movement, others used for moving incisors. The Schwarz appliance is used for bilateral maxillary expansion. It's a two-piece expansion appliance. The Y-plate appliance is a three-directional expansion where we can move the anterior segment, left posterior, and a right posterior segment separately, known also as three-piece expansion appliance. The appliance on the bottom left has a fan-shaped screw which expands the anterior region more than the posterior region. The W-arch, it is a fixed appliance for slow expansion. Be considered a modification من الcoffin spring اللي هو removable appliance. Fixed appliances does not require patient cooperation. نحن بنلزقه له في البق فهو ما بيقدرش يشيله ولا بيقدر يتحكم فيه زي ما بيتحكموا في الcoffin spring وفي الexpansion screw appliance. بيبقى معمول من واير 0.9 مليمتر stainless steel wire. بيبقى shape واحد ال W. This wire بيبقى solder للmolar bands على first permanent molar palatally. ولما بيجي يعملوا له solder بيبقى لازم يبقى away من palatal mucosa 1 ل 1.5 مليمتر عشان ما يبقاش عامل pressure على palatal mucosa و cause irritation.
The W arch بيبقى easily activated simple by opening الapices بتاعت ال W arch. يعني لما بنعوز نعمل activation anteriorly we pull ال free arms بتاعت ال W arch اللي هي زي ما شايفينها في الإيمج وواصلة resting لحد ال lateral incisors. we pull it outward لبرا يعني in a labiobuccal direction. ده هيعمل لنا force على الانتيريورز فهتعمل expansion anterior. طيب لما بنعوز نعمل expansion posterior بنعمل opening للinner U shape بتاع ال W arch عند المولر bands. بن open it in a buccal direction لبرا علشان يعمل posterior expansion. We can use the W arch علشان نعمل expansion anterior alone أو نعمل expansion للposteriors alone أو نعمل expansion anterior and posteriors equally أو نعمل كمان expansion anterior ممكن يكون more than the posterior أو vice versa العكس posterior يبقى expansion فيه أكتر من anterior. When the lab بيبعت لك ال W arch appliance appliance بيبقى passive يعني it does not exert any force on the teeth. We start our first activation by opening the appliance 3 to 4 millimeter before we fix it in the patient's mouth. Then we see the patient every month. We remove the appliance and activate it again by 2 millimeter. We carry on the activations every month till we correct the crossbite. We always do an overcorrection يعني بنصلحها بالزيادة شوي. Why? عشان we have always to put in consideration a rebound or relapse that might take place. The quad helix appliance is another fixed appliance used for slow expansion. It is the most commonly used appliance in the deciduous and mixed dentition patients. This appliance is made of 1.2 millimeter stainless steel wire soldered to the bands of the upper sixes or the upper E's according to the patient's age. The quad helix appliance is so similar to the W arch appliance, but with 4 helixes. These helixes increases the length of the wire, causing the flexibility and the range of the wire to increase. So we can do more activation with this appliance when compared to the W arch appliance. The activation of this appliance is carried by opening the appliance 8 millimeter, which produces a force around 300 to 400 grams on the teeth. We use the quad helix appliance to correct the crossbites seen with constricted maxillary arch cases and with cleft lip and palate cases. The nitinol expander is a ready-made expander that we attach to tubes on the upper first permanent molars palatally. The center part of the expander is made of thermally activated nitinol alloy, which is characterized by shape memory and superelasticity. So when we subject the expander to a cold using freeze gel packs, they become more and more flexible, and we can easily compress it and seat it in the patient's constricted maxillary arch. As the expander starts to gain heat from the patient's body temperature in the oral cavity, it starts to recover its initial form, producing forces on the teeth as it regains its shape back. The forces produced by this appliance are uniform, continuous forces, around 230 to 300 grams. As you can see in the top image, the nitinol expander is compressed when it's initially placed. In the bottom image, it is obvious that the expander returned to its initial shape and arch expansion occurred. The nitinol expanders comes in 8 different sizes according to the intermolar width. It ranges from 26 to 47 millimeters in width. Also found with softer wires in sizes ranging from 26 to 32 millimeter in width, which are commonly used for younger patients with deciduous dentition. How to select the size of the expander? We first measure the mandibular intermolar width of the patient, and since the maxillary arch normally occludes buccal to the mandibular arch, as we all know, we add 1 to 2 millimeter to the mandibular intermolar width that we previously measured. As we said before, we always do an overcorrection, so we need to overexpand by adding an extra 2 to 3 millimeter. So the size of the expander that we are going to select will be equal to the sum of the mandibular intermolar width of the patient plus 3 to 5 millimeters. In some cases where we need more than 8 millimeter expansion, 2 expanders will be used, as one expander will not be enough to gain 8 millimeters. Expansion takes around 1 to 2 months in early mixed dentition patients, while in adolescents it takes a longer time, around 3 months. The retention period should be 50 to 100% the time taken for expansion. For example, if it took 3 months to expand the maxillary arch, then the retention period should be from 1.5 to 3 months. The second type of expansion, according to the rate of expansion, is the rapid expansion. Rapid maxillary expansion is also known as rapid palatine expansion or split palate. Why we call it split palate? The rapid expansion is a skeletal expansion in which we separate the two palatal bone away from each other at the mid-palatal suture. When we do rapid maxillary expansion, what happens? Rapid maxillary expansion has both skeletal and dental effects. On the maxilla, as we said, it causes separation of the two palatal bone and opening of the mid-palatal suture. It also causes downward and forward movement of the maxilla. On the maxillary teeth, appearance of a diastema in the midline between the two maxillary center incisors. The crown of the maxillary posteriors becomes buccally tipped and the teeth becomes extruded. The extrusion of the maxillary posterior teeth causes the mandible to rotate downward and backward, thus increases the facial height and decreases the overbite. Rapid maxillary expansion also facilitates the respiratory function by reducing the resistance to the nasal airflow and increasing the internasal space. There are several appliances that are used for rapid maxillary expansion. These appliances are fixed appliances which can be classified as tooth-borne appliances that depends entirely on the teeth for their support, while tooth and tissue-borne appliances depend on the teeth and other tissues like the palate for their support. The tooth-borne appliances include Isaacson appliance and the Hyrex appliance. The tooth and the tissue-borne appliances include the Dairy-Swiler appliance and the Hess appliance. The Isaacson appliance consists of a special spring called mini expander that is soldered to the bands on the first premolar and the first permanent molar of maxillary arch. The mini expander consists of a coil spring and a nut. To activate the appliance, we turn the nut to close on and compress the spring, producing expansion forces on the posterior teeth. The Hyrex appliance consists of a special screw called hygiene rapid expander, which have two heavy wire gauge extensions of 1.2 mm thickness projecting from each side. We adjust these wire extension in the lab to adapt and follow the contour of the palate. Then we solder them to the bands on the premolars and molars. These screws may come in different sizes, such as 8 mm, 9 mm, 11 mm, 12 mm, which denotes the range of action. The image shows the Isaacson appliance with the mini expander and the Hyrex appliance with the hygiene rapid expander. Both expanders are soldered on the bands of the premolars and the molars. Since these appliances have their support from the teeth only, they are considered to be tooth-borne appliances. In the Dairy-Swiler appliance, the first premolars and the first molars are banded. We make small wire tags and solder them to the bands of the premolars and the molars from the palatal aspect. The acrylic part of the appliance is splitted in the middle and it incorporates the wire tags projecting from the bands. It also incorporates a screw in the center. The acrylic might extend to the palatal surface of the second premolars and the canines, but do not reach the incisors. The Hess appliance is used in patients in late, mixed, and early permanent dentition stages. It consists of bands on the premolars and the first molars together with a length of wire which is adapted to the palatal aspect of the premolar and molar bands, then soldered. The free ends of the wires are bent 90 degrees and embedded in the acryl together with a screw in the center of the acryl. The disadvantage of the Hess appliance is that it is difficult to bend and cement the appliance on deciduous or malpose teeth. The image shows the Dairy-Swiler appliance has wire tags soldered to the palatal aspects of the bands of premolar and molars, while the Hess appliance has a length of wire adapted to the palatal aspects of the premolars and the molars, with its free end turned and embedded in the acryl. Since these appliances has their support from the teeth and the palate, they are considered to be tooth and tissue-borne appliances. In this image, the Hess appliance looks similar to the Hyrex appliance with the exception that the Hess appliance has acrylic parts on the palate, which makes it a tooth and a tissue-borne appliance. How to activate rapid maxillary expansion appliances? There are several activation schedules that has been suggested. Dr. Tim suggested that in patients up to 15 years old, the screw is turned twice a day, quarter turn in the morning and quarter turn in the evening till we finish the needed expansion. While Dr. Zimmering and Isaacson in 1965, they recommended that in young growing patients, for the first 4 to 5 days, the screw is turned 2 quarter turns each day. Then later, 1/4 turn each day for the rest of the expansion treatment. While they recommended for a non-growing adult patient, for the first 2 days the screw is turned 2/4 turns each day. Then for the following 5 to 7 days the screw is turned 1/4 turn each day. Then afterwards the screw is turned 1/4 turn day by day till we achieve the needed expansion. Rapid maxillary expansion is indicated in posterior crossbite cases and constricted arches found in class 2 and class 3 malocclusions, also found in cleft palate patients. It is indicated when class 3 patients undergo face mask therapy, also indicated when the respiratory function is impaired, as in cases with nasal stenosis and septal deformities, as expansion makes respiration easier. Rapid maxillary expansion is contraindicated in uncooperative patient, as we need a cooperative patient to follow the instructions to activate the appliance and carry a proper oral hygiene. As the rapid maxillary expansion increases the facial height and decreases the overbite, it cannot be used in cases which have anterior open bite, increased Frankfurt mandibular plane angle, or an increased facial height, as it will worsen the case. With rapid maxillary expansion, the mandible rotates downward and backward, causing the profile to be more convex. So we cannot use the rapid maxillary expansion in convex profile cases. It is contraindicated in adult patients with severe skeletal problems, such as skeletal maxillary and mandibular asymmetry, severe anteroposterior and vertical skeletal discrepancies, as these cases requires orthognathic surgery. Rapid maxillary expansion is contraindicated in all patients because the sutures are ossified and it will not be possible to open the mid-palatal suture. We do not use rapid maxillary expansion to move a single tooth in a crossbite. Neither it is used when the maxillary molars are periodontally compromised for the risk of losing the teeth. Hazards and risk of the rapid maxillary expansion can occur if the patient is uncooperative and not carrying a proper hygiene control, and if he is not following instructions for activation of the appliance. The length of fixation of the appliance in the mouth will be longer, together with the accumulation of food and plaque will increase susceptibility to caries and tissue inflammation and even infection in the gum and palatal mucosa. The appliance might break and dislodge in the mouth, causing some tissue damage. With the activation of the appliance, some patients might feel pain and discomfort, while others can feel some pressure at the bridge of the nose. When we compare the slow expansion versus the rapid expansion, we'll see that the force produced by the slow expansion is a light force ranging from 10 to 20 Newton, while the force produced by the rapid expansion is a heavy force, ranges from 50 to 100 Newton. The slow expansion has an orthodontic effect. Its effect on the tissue is mainly dental effect with some skeletal effect, while the rapid expansion has an orthopedic effect. Its effect on the tissue is mainly skeletal with some dental effect. The slow expansion is activated from 0.5 to 1 millimeter per week, while the rapid expansion is activated from 1 to 1 millimeter per day. The treatment duration is 2 to 4 months in the slow expansion and is 1 month only in the rapid expansion. We can use both fixed and removable appliances for the slow expansion, but for the rapid expansion, we can only use fixed appliances. Lesser changes occur in the arch length parameter with the slow expansion, while greater changes occur with the rapid expansion. The change in the intercanine watts is nearly the same for the slow and the rapid expansion. There is no effect on the mandible with the slow expansion, while the rapid expansion causes the mandible to rotate downward and forward. The treatment results are more stable in the slow expansion than in the rapid expansion. The relapse tendency is low in the slow expansion and is higher in the rapid expansion. The retention period is short in the slow expansion, around 1 to 3 months, and longer in the rapid expansion, around 3 to 6 months. Thank you all for listening and wish you all the best.